Pananda, everybody, good afternoon, Croeso, welcome to the penultimate session of the final leg of a long but very seminal week for the future of value-based care in Wales. I'd like to extend my huge congratulations to the national team for hosting such a successful event. I've dipped into as many sessions as I could during the week, and I've followed events on social media, and there's a definite buzz and movement towards embedding the principles of value-based care across Wales. I read a lovely tweet this morning from someone from NHS England who was really complimentary of the collaborative shared learning approach that we've adopted across Wales, which I thought summed up nicely the ethos of the last 7 days. Hopefully we can extend that for the next 45 minutes and you can come out of the session learning something new and something which you can apply in your own practice going forward. Next slide, please. I want to introduce, we're a double act this afternoon. I want to introduce ourselves, but there's a significant project team that are not here today for several reasons, who I will mention in the next slide. But just to introduce the two people who are here that we lead in the session today. My name is Neil Windsor. I'm Deputy Director of Transformation and Improvement and Head of BCU Pathways. But I'm a complete fraud here today. I'll be completely open and honest. I've had virtually nothing to do with this whatsoever, other than to commission this project and to get regular updates on it. But I've had absolutely nothing to do with the delivery of it. But I've got the really exciting part of actually espousing the virtues of the project that the team has delivered. Just as a quick aside, this is an exciting time for Betsi in the world of transformation. We've just appointed a new director who has a wealth of experience in senior transformation roles in private industry, and we have an emerging function which includes an explicit improvement of BCU pathways function and supported by a transformational analytics function, and for the first time a dedicated value-based care unit. And I'm delighted to say that we advertised for our inaugural head of value-based care yesterday, placing the model at the forefront of our future transformation ambitions. That's enough about me and the team for a second. I just want to hand over to Ian Starks for Ian to introduce himself as well.
Hi, my name is Ian Starks. I'm a hip and knee arthroplasty surgeon and I'm clinical lead for TNO in Wrexham. I'll hand you back to Neil.
Okay, thank you. Next slide, please. I have the clinical lead sat next to me, and I've got to watch what I say now, but even as the clinical lead for orthopaedics in North Wales, and this is a presentation espousing the virtues of our PROMs-led virtual thought pathway for orthopaedics and for hip and knee arthroplasty, of which Ian is a hip and knee surgeon. He's not even the most important person in this project either. I hope he doesn't mind me saying that. There's a huge project team, and I want to just reference a few people, and I'll talk about other things, probably the most important now. I wanted to reference Ian Wilson. So Ian's a consultant orthopaedic surgeon. And at the start of this project, there was an element of Ian will agree with me of clinical ambivalence, apathy around this project to start. And Ian Wilson was the orthopaedic surgeon that put his head above the parapet, put his hand up and said, actually, I think this idea's got legs. I'm happy to do the proof of concept and clinically lead the proof of concept. Ian Starks has then been instrumental in driving this project forward in the post-COVID period, particularly. I want to quickly mention Debbie Taylor, who's a member of my service improvement team, who's taken this from a conceptual idea to actually developing the idea and driving it forward. Bob and Alison were really important as they're members of our costings team, who were working with us previously from a nationally commissioned piece of work on time-driven activity-based costing for hip and knee surgery to start to map out the entire pathway end-to-end from a cost perspective, and then came to work with us on this project right from the start. And I think they've added a level of maturity in terms of our outcome data, in terms of aligning improvement and outcomes with cost as well, which has allowed us to really move this from a traditional improvement project to a value-based care project. And last, no means least, I want to reference George. George Poole is probably the most junior member of our team, but probably the most important member of our team. So we were allocated external funding from the National Planned Care Programme to appoint a PROMs coordinator to support us with the development of alternative pathways of care for orthopaedics, and we've appointed George on non-recurrent monies, which poses its own problems, which I'll come up to later, but George has been integral and probably the most important person in terms of leading this project going forward. And if there's a question, I'll preempt a question at the end which says, what do you need to deliver this project going forward? You need to find a George, because he has been important if you want to deliver PROMs-led virtual follow-up. Next slide, please. What we want to get across in the next 30 minutes is the scale of the adoption and delivery in the post-COVID period of our PROMs-led virtual follow-up pathway has been impressive. But whilst in vogue, virtual clinics are not new, and our transition into the space from an orthopaedics perspective can be mapped over the last 8 years. So this is very much a slow burner, and the rest of the presentation is going to focus on that latter end of this timeline from February 2019 onwards, but there was a lead up to that. Next, please. So we've been in this space in terms of virtual outpatient clinics since 2010. My team worked with the SHINE project as part of the Health Foundation back in 2010 to deliver the implementation of a virtual cardiology clinic. And this was about having alternative pathways of care and reducing the need for face-to-face consultation for cardiology patients, but it was very much in the new patients space. Next, please. Then in 2013, a paper came out, a multi-authorship paper from a team in Manchester, orthopaedic team in Manchester, including a shoulder surgeon by the name of Betsi Cadwaladr, that was looking at the use of PROMs to triage the need for follow-up outpatient appointments for shoulder surgery. So they were using the Oxford Shoulder Score to determine the need for follow-up appointments. This was a really, really small study. There's only 36 patients in this study, but what they found that 83% of those patients did not require face-to-face consultation going forward. Next, please. This was then taken further by the SHINE programme of 2014, which looked at the use of virtual outpatient clinics for follow-up hip and knee surgery. And again, this was using Oxford hip and knee score and an X-ray to triage the need for follow-up outpatient appointments. They put 300 patients through this system as part of this project. 0% DNA rate as part of it, and one of their outcomes was that they could see 5 patients through this virtual model to 2 patients through a traditional face-to-face model. Next, please. Then Betsi Cadwaladr, who was in that original Manchester group of the original project, that had moved on and moved his project on, and he was presenting nationally. I was at these national events that you get invited to on transforming outpatients, and he was presenting on the use of PROMs data to run virtual orthopaedic clinics. And Biv has become a HSJ innovator at this point, and the NHSI lead for virtual outpatients. Next, please. By 2016, February, Prudent Healthcare Security, Health and Wellbeing for Future Generations was launched, and that was a national focus in the same area, which 2 of the elements of this paper was to do what is only needed and no more, and that there was a call to arms to change the model for outpatients going forward. Next, please. Following that, in February 19, there was an explicit focus from the National Planned Care Board, which requested health boards to reduce trauma and orthopaedic follow-ups. Next, please. And we worked, and I commissioned a team within Betsi to look at this, and October 19, our first PDSA was commenced with Ian Wilson, who were referenced previously in Wrexham Minor Hospital. And as I said, there was a clinical apathy, and everybody's aware of the work of Peter Fuder. There wasn't a burning ambition, or there wasn't a burning platform to really change here, even though we have the national mandate. Next, please. And then finally, a wider proof of concept with all consultants at Wrexham Minor Hospital commenced, and this was really quick from the first proof of concept with one consultant. Unsurprisingly, what happened in March 20, COVID hit for the first time, and we couldn't see our patients face to face. So we had a burning platform to deliver change on a wider scale, which we've then transitioned to a burning ambition to really change the way that we deliver the model of our patients going forward. Next, please. Just to put it into context, in that period of October 2019, we had the highest orthopaedic follow-up waiting list in Wales. And if you take Cardiff out of that equation, it's significantly higher than the other health boards. And we've done some work previously to reduce this. So we have reduced that, but at this time it's begun to flatline in terms of improvement of numbers. Next, please. So we said we started a little bit earlier on when the edict came out in February 2019. The focus very much to start was on the traditional way that we deliver. How could we tweak the traditional way we deliver our patients? And very much that was on validation. How do we validate the waiting list to make sure that everybody who's waiting needs to be there, etc. Next, please. It focused on this first quadrant on traditional clinics, so what we call synchronous delivery of outpatients. So the patients and the clinicians are present there together. So whilst we try to change this in terms of looking at telephone-led follow-up or the use of virtual technology to support real-time but virtual uses of outpatients, so teleconferencing type facilities, Teams, etc., Attend Anywhere, to develop a synchronous model. What we find and what the other studies found, that there wasn't a huge difference in terms of clinical efficiency in terms of these clinics. That needed the same amount of resource, if not more resource, to do Attend Anywhere type virtual clinics. And the efficiency in terms of the number of patients that went through didn't change whatsoever. So very much we started working, next please, on this bottom quadrant, quadrant 3, which is very much the asynchronous model of delivery of virtual models. So that is, the patients are not present whilst the triage is taking place. Next, please. Next, and again, thank you. So the emerging hypothesis, which we started mulling through once we discounted Attend Anywhere as a real game changer and telephone-led follow-up and on all of the other strategies that we'd looked at in terms of including validation. We were looking in that third quadrant space, and what we started to get this emerging hypothesis that we could use PROMs data to aid clinical decision making. So that was the real embryonic part of our emerging hypothesis. Next slide, please. And then that sort of evolved to, could we use the Oxford knee and hip scores and an X-ray as part of our review process for a follow-up hip and knee arthroplasty? Next, please. And then we took that stage further, and our final hypothesis was that a sizable proportion of our arthroplasty follow-up demand could be managed virtually and asynchronously through an office-based decision clinic without the need for the patient to be present. And that formed the basis of our PROMs-led virtual follow-up clinic. We bring Ian in for a second at this point, because he was conscious that he wanted to reference some other people that were seminal in terms of building this hypothesis, particularly the lead team and the national panel.
So I think the seed for me came from a British exercise meeting where Martin Stone who's a surgeon in Leeds, centred his work on virtual follow-up, and he's done a whole wealth of work and designed his own pathway that has been through Delphi modelling and validated. So, and over a similar time, we then had a visit from Phil Thomas from Cardiff, who came up and gave us his own personal experience using PROM scores for virtual follow-up of this group of patients. And so I think when Neil used the word apathy, it wasn't apathy that stopped us progressing. It was just that we weren't able to agree on the best way of taking this project forward. But we knew that with the data that Martin Stone had produced, that probably 90% of these patients don't require a face-to-face follow-up because they have actually no issues with their joint replacements. But how we could take that portion of patients and still follow them up in an alternative way virtually, and then use our time more efficiently, we just couldn't come up with an agreement on until really COVID hit. And then that was, that just made us then push the decision into saying, well, actually, we will just go down the using PROMs data and see how we get on with that. I'll hand you back to Neil.
Great. Thank you. Next slide, please. So I'm not going to dwell on this for anybody who doesn't know what the Oxford HIP score is. It's a 12-question scoring system which focuses on post-operative quality of life, quality of life, collected at pre and post-operative stages as well. Next slide, please. So we have 3 primary objectives. You can go through all. That's it. Thank you. So imperative to what we were doing was that whatever pathway which we put in as an alternative, focus on care quality and safety should be maintained and enhanced, and we should have metrics to show that. We wanted a more efficient service, hence why we got out of the first quadrant about the synchronous face-to-face solutions, and we should be able to reallocate resources to areas which show greater efficiencies, and then we wanted to add value as well. So we wanted it to be cost effective. We want to prove that, hence why we got the costings team in from day one. And we wanted to be able to recycle, reuse spare capacity as well, because we've got significant follow-up backlog, but we had a significant new patient stage 1 backlog as well. Or could we reallocate some of this capacity for stage 4 inpatient activity as well? Next slide, please. So our approach was, as Ian said, is we needed to sit down and sort of design and clinically agree a model which was clinically agreed through all of the arthroplasty service in Wrexham. So we used traditional improvement techniques, and my improvement manager supported this in terms of value stream mapping. We mapped the process pre-change, and then we came to a clinical agreement in terms of the way forward. Next slide, please. So this is the pathway. So patients discharged from hospital, they had a 6 to 12 week post-op wound check, which was face-to-face back in the outpatient clinic in orthopedics. They had a 1-year face-to-face review, a 3-year face-to-face review, potentially a 5-year face-to-face review, just to say that not everybody had a 3 and a 5-year face-to-face review. So for the costings perspective, we've only taken one of those outpatient clinics in terms of the costing perspective, but some did have 3 and 5, and then a 10-year face-to-face review. So going back to our hypothesis, what we were testing is, do these patients need the level of face-to-face consultation that they had historically, or could we use PROMs data and X-ray to triage that need? So the new pathway which we had was, next please, discharge for hospital. We kept the 6 to 12 week post-op wound review. We had a 1-year virtual review, and next again, if you can go next again. So that gave 2 outcomes. If the patient was over 75 with a 10A rated implant and a good PROM and a positive X-ray, this patient was discharged to SOC on symptom pathway. If there were any concerns at this point, then they would then default back into the traditional pathway. Next, please. If they didn't meet the top criteria in terms of being over 75 with a 10A rated implant, but the PROM was positive and the X-ray was positive, then they would just then have a 7-year virtual review, again a review of their PROM score and their X-ray. And next, please, they would have a 10-year virtual review. So you can see in terms of potential face-to-face consultations post-operatively, potentially is just a 6 to 12 week post-op wound review in comparison to the traditional pathway. Next, please. So just in terms of, is anybody wondering what the admin process was around that? So patients were identified suitable for virtual pathway based on their progress at their 6 to 8 week wound check, and through an office-based decision on WPAS, they were referred to the virtual clinic. Then patients booked into a virtual clinic slot on WPAS. The consultant reviewed the PROM and the X-ray and the case notes and made an office-based decision, which was either book them for a face-to-face appointment because there was an issue or a problem, they were discharged, or they were continued for virtual monitoring. Next slide, please. So what were the results? We've sent 424 PROMs out using predominantly the national PROMs portal, so these have been sent out electronically. We've had 395 PROMs returned with support from our PROMs coordinator, which is 93% return rate, so a massive return rate. And the reason for that is George. So George monitors every PROM sent out and every PROM returned, and if a PROM hasn't been returned, he will phone the patients up and handhold the patients through that PROM collation. So he will support them right the way through. So if patients are not technically savvy, he will phone them up, and then we will do it via a paper-based system, or he will support them through their journey of presenting their PROM through the electronic solution. Next slide. But the question is, so what? So out of those patients, 338 patients to date have been booked into a virtual clinic for review. Next slide, please. And the outcomes of those, we've got outcome data for 322 of those patients. So the patients that we haven't got outcomes for are the patients that, when I did this data trial last week, are those patients that have been outcomed in the last few days when we were pulling the data. So we haven't got that outcome has not been then pulled into the system yet. So that's the only reason why we haven't got outcome data. So we've got outcome data for 322 patients. So of the 322 patients reviewed in the virtual follow-up clinic, 196, 61% continued on the virtual pathway without the need for any other intervention. 84, 26% were discharged. 22.7% required a face-to-face consultation because of concerns or issues with either their PROM score or with their X-ray, and 20 patients, 6%, had a telephone review. Next, please. So that tells us that 93% of the cohort of the patients in this trial, which is significant, 322 patients, don't require face-to-face consultation. Just remember back to the traditional pathway, these would have been followed up at 1 year, 3 years, 5 years, 10 years. Next slide, please. So costings. So we're not going to go through this slide other than to say we've costed this out in its entirety, right from an end-to-end perspective from the post-operative period, to get a definitive cost of how much this pathway has cost us against the pre-change pathway. Next slide, please. And again, thanks. So what does that tell us? Well, that tells us that standard pathway costed £243.19 patients to get a patient through our follow-up pathway, and our PROMs pathway is costing us £224.62, which is a saving of £18.57 per patient. We think so. As part of that, what we've costed out at the moment is a standard follow-up clinic costs us face-to-face costs us £62.22, and a clinic undertaken virtually per patient is costing us £56.78. But what we think is that we've overestimated the cost of that, and we've been very conservative in the cost of that. So we know there's a paper that's been presented in 2021, the cost analysis of virtual clinics following primary joint arthroplasty, which says a virtual a virtual clinic costs £25 per patient. A consultation is £25 per patient, which would make a significant reduction in the differential between the standard pathway and the PROMs pathway. We think that we're putting in a solution in which will reduce our cost to £34.59, and when we do that, that will increase the variance between the two pathways to £66.57 per patient. So significant, then you start to get a significant difference per patient, but still significantly more than what the paper is suggesting. Now you've got some ideas of why that is, don't you? And you think it's overestimated?
I think we're overestimating because we're including the cost of collecting the PROMs, which is a process that we're expected to do anyway. And so, in my opinion, shouldn't be included in the calculations because that's something that's going on sort of parallel to this process. And what's also not included in the costing and the modelling is the additional capacity created for myself and my colleagues to see those patients that really need to be seen and try and plough through some of the backlog of long waiting new patients that we've got out there.
Okay, next slide, please. So if you extrapolate that to the number of patients that we arthroplasty patients that we had on our waiting list in the summer of 2021, you're talking about a whole pathway saving across BCU of £60,000, almost £61,000, with the lower estimated cost per clinic, or the most costly virtual clinic cost, which would then go down to £218,000 worth of savings if we rolled this out pan BCU. Next slide, please. I must admit, we haven't done a lot of formal assessment of patient experience. That's probably the one area of omission at the moment with the project. But we have got anecdotal data in terms of patient experience with this. One of our patients, Robert, had a total hip replacement in 2019, has gone through the virtual follow-up pathway. What he said was, remote follow-up appointments ensured I felt connected to the service without having to visit the hospital. They asked the same questions that I'd asked if I went to the hospital. I don't have to travel, I don't have to wait around, everything is easier. If there's a problem, they call me to be examined. It works well for everybody. So I think we've had some really positive anecdotal evidence in terms of the benefit of this from a patient perspective. What we haven't done is a formal review of patient experience as yet. Next slide, please. So what were the other benefits? Well, Ian alluded to, virtual clinics need 50% less time allocated per patient, increasing productivity per clinical session. Excess follow-up capacity can be reallocated for a growing new patient demand, but we're nowhere near that yet because of the level of follow-up backlog we've got at the moment. So that is the future ambition for this. It reduces stress on hospital infrastructure, particularly during COVID-19, and it meant that outpatient consultations could continue in the COVID period, but very much it's stopping both the stress on the hospital infrastructure and the wider community stress on the carbon footprint that the continuous appointments into hospital create, as it reduces that unnecessary carbon footprint, and we've had a positive patient feedback as well. Next slide, please. I'll focus on one. We'll talk about constraints because it's not all been rosy during this journey, and COVID has been an enabler and a constrainer to this as well. So if you look at the number of patients booked into the virtual clinics, we've got a significant. Next please. So we mentioned this was one clinician to start with. So we only booked a few patients in because there was a proper PDSA, one consultant to start with, and then when we had the clinical buy-in because of COVID as the burning platform to change the way that we deliver this, we couldn't actually see patients or review patients because there was a restricted X-ray capacity due to COVID. So whilst we had this ambition for 6 months, we were really constrained in the numbers that we could put through our virtual outpatient clinics because of restricted X-ray capacity. Next slide, please. Next again, please. And then when we were following up those patients that had been delivered and we were at the 12-month stage, we had 6 months of a loss of activity because of COVID, where we weren't doing inpatient activity for orthopedics because it wasn't given essential service status during the first wave of the pandemic. So at that 12-month period, we didn't. So we were collecting PROMs data at 12 at the start of the patient's journey, but in 12 months time, when they should have had surgery, we should have been getting follow-up data. We had a huge gap in terms of follow-up patients because of the lack of elective activity that had happened in that period 12 months previously. Next slide, please. So next steps, last slide. We want to secure funding for the 3 PROMs coordinators and roll out the model across the 3 sites as part of the wider redesign of our arthroplasty pathway, which Ian's leading. So we will be leading a pan-BCU redesign of an entire arthroplasty pathway, which will include a standard BCU way of how we deliver follow-up appointments, including virtual PROMs. George, who's been leading this, is appointed on non-recovered money, so he's only temporary at the moment, and he's integral to this program. And if we lose him, we lose a significant amount of skill and insight into this program. So we have got funding for 3 years, but it's been a journey to get funding to extend George and to put PROMs coordinators on the 3 sites. Want to develop a formal data collection of patient experience. We want to review the application of model for other subspecialty conditions. I mentioned Bibis Roy, who was the lead in this back in 2013. He was doing this in 2013 for subacromial decompression, for shoulder surgery. What other subspecialties in orthopedics would this lend itself to? What other specialties, non-orthopedics, would it lend it to as well? And I'm bringing you now because he wants to take this a stage further. Now we want to develop a business case for an arthroplasty care practitioner as well.
So again, this is following on from the work done by Martin Stone, and it's looking at ways that actually we can remove, consultants completely from this process. So our time is then solely focused on dealing with those patients that have problems and issues. And arthroplasty care practitioners and training out reporting radiographers to review the X-rays in a systematic way is one way that we can potentially do this in a cost-effective way. As I say, also utilising our skills more where they're needed as well.
Next slide, please. I think that's it. I think that is the end of our presentation. Not done too bad in terms of time, slightly over, but we will start with the question and answer session. I'm conscious there's a few questions in the chat box, which I'll begin to read out, and I'll begin to answer, and I'll bring Ian in to support me with answering these as well. So the first one is, have you been able to reallocate the savings made through the service redesign? The first thing, I'll bring Ian in now. The first thing I would say is this is not cash releasing savings. I want to be quite clear, this is not about releasing cash. This is about providing capacity to reduce backlog. So what we should be able to do is more within our same capacity. We will not be stopping outpatient consultations as a consequence of doing this, but what we might do is reduce our need for WLIs to reduce our outpatient backlog, etc. Or we will reprovide the consultant capacity into either more backlog reduction, translating the capacity into additional capacity to look at new backlog, or maybe even looking at changing job plans for reallocating consultant time for say for stage 4 activity for inpatient activity.
I think it's just making the whole process work a lot more efficiently, and at the same time providing patients the option to have an X-ray closer to home for them at a time that's more convenient for them, and then not having to travel, to report that they've got no issues with the joint replacements. Often they then spend hours sitting around in a clinic that that's overrunning. So I think the whole process is just much more efficient for everybody. With regards to the question about feedback from patients, I know Neil alluded to that, but we are in the process of formally collecting data for this. But as Neil said, the initial response from patients feedback has only been positive. I think I answered earlier the question with regards to buy-in from the clinical team, and it's having trust. It comes back to George, who our data collector, just been pivotal to the whole process, and as Neil said, probably the most important member of the team.
In terms of the patient feedback, you've got to remember these are patients who have got to arrange childcare, have got to arrange time off work, have got to arrange other elements of their life to come to a clinic. They'll have a significant issue, particularly in Wrexham, in terms of parking. Actually, if anybody knows Wrexham, you'll have significant issues trying to get to them either at the moment, given the amount of roadways that are in there. Also, there was a huge amount of life rearrangement and stress to get to outpatient consultations. So in terms of our patients are confident that there is a scientific way of us to triage the way in which we determine the need for patients to need to see consultants face to face. And I think that scientific element in terms of a consultant having outcome data and an X-ray to determine that gives them a level of confidence that we only need to see the patients that need to be seen. There's a next question. Have you thought of quantifying the other cost savings, financial for patients, environmental, tons of CO2, etc.? It's a really, really good question. I was in a meeting with our director and our head of informatics yesterday because I want to start getting some data and building a analytics measure as part of the wider improvement programme in terms of the societal impact of what we do. I was quite conscious of a presentation I saw last week at the Planned Care Summit with the Minister and Hamish Lane last week, and he talked about the carbon footprint that hospital consultations have in Wales, and I've never seen it, and I can't remember what it was in terms of a percentage of the total carbon footprint in Wales. A significant percentage of that was from healthcare and from outpatient activity as well. It was quite a startling amount. But I'd like to do something in terms of the societal impact of what we're doing. How do we use the PROMs data to show patients who are off work and patients who we can get into work and into full employment and to live a full and active life, and to really pay an active part of the community, etc. And as I said, everything in terms of that life element that patients have to go through in terms of travel and taking time off work and childcare, etc. There's a whole host of other measures which we never ever look at in terms of that societal impact of what we do, which I would love to start bringing into this type of work as well. There's another question. Have PROMs allowed you to identify cohorts of patients that don't benefit much from arthroplasty and those benefit the most, as has happened in cataract? So are we using the PROMs data to focus on those that are not getting the best outcome?
I think PROMs data probably, our data confirms what's already out there in the scientific literature, that we know patients that are in, the longer patients have waited and the poor physiological state they're in preoperatively, the less likely they are to get a good outcome. But we're still seeing patients that have got very low scores still doing very well, and I think if anything it shows actually that even for people that are in a very bad way are actually they've got huge benefits still to be had from joint replacement surgery.
I think one thing you were keen on previously is to highlight the length of delay in Wales having an impact on the PROM outcome.
So one of the things that we haven't looked at yet, but what we would probably, I'm keen to look at, is looking at our preoperative PROM scores post-pandemic or peri-pandemic compared to those from pre-pandemic, as the waiting lists have gone up as a result of the COVID pandemic. I suspect we'll be seeing patients' preoperative scores considerably lower as a result of the length of times that they're having to wait.
One of the things that our costings team are looking at the moment is there is a differential in terms of the cost of implant used across Betsi, and we can start doing some work in terms of what's the correlation between cost of implant and outcome data. So there's, you know, some other data, there's some other elements that we can cut this data and use it to in terms of determining our actions going forward.
So I think if I could answer the question on tips, I think having a good data collection clerk is pivotal to this whole process. And I would say we spent a long time going around in circles, primarily because of concerns that the PROMs, you know, Oxford Hip and Knee scores have never been validated for virtual follow-up, which was a concern for some of us, myself included. And I would just say, I think, you know, we've seen that it can work firsthand, and hopefully we'll be able to write this up and go some way to validating it. But I would just say, just do it. I think, you know, our experience has only been a positive one, and I'm sure it will continue to remain positive. And if that follows on into the next question, is then looking at ways that we can then roll it out to our colleagues in the other subspecialties within TNO, the next stage.
The previous questions in top tips, my answer would be, why wouldn't you do it? If we've got a cohort of 300 patients, we've said that 94% of them patients don't need face-to-face consultation, means that we can double the rate of reviews. It means that the patients are benefiting because they're not having to come in for needless face-to-face consultations. It's cost effective, it benefits the patients. We can reallocate unnecessary clinical capacity into necessary clinical capacity, whether on stage 1 or stage 4 capacity. Why wouldn't we do it? In terms of the next question, in terms of what would we do for TNO, I'd like to widen that question. Why does it have to be TNO? I'm sure, you know, it's an element of surgery and neurology, in gynecology, in general surgery, in ophthalmology that we could use this model for. I'm sure there is. As I said, Bibas Roy, who was very much the lead in this in 2013, is shoulder surgeon, and he's done shoulder surgery previously. But I think stage 1 for us now, we've done proof of concept, is to roll this out across Betsi, across the other 2 sites, Glanford and Bangor. So this is the way that we do this across North Wales, and embed that into the regional pathway redesign for hips and knees, which Ian's leading on going forward. So getting that clinical consensus, that's the way we do things in Betsi, is the first stage. But the push to Wrexham now is actually, you've done this now and it's almost business as usual now. So what, where do we go next? So that's the challenge back to the clinical and the HMT in Wrexham at the moment. And I think I don't see any more questions. So if there aren't any more questions, literally, if anybody wants to post a question now, please feel free to. And if not, we will look to, with probably about a minute to do, maybe wrap up the session. From myself and Ian, just to say a huge thank you for inviting us. We love, sometimes we feel so isolated in the north and that, but we love sort of presenting the work which we do, and it's been a huge honour and a huge opportunity for us to sort of espouse the virtues of our programme.
Thank you.